I would like to start by thanking Dr. Margaret Mann and Dr. Sergio Gianesini for inviting me to give this lecture about global guidelines in sclerotherapy. I don't have any conflict of interest to declare. I am very passionate about sclerotherapy because as a group in Peru, we have treated thousands of patients with high success rates. This presentation is derived from the lecture presented at the Winter International Meeting held in Cortina d'Ampezzo in 2019. We have reviewed many guidelines and expert consensus and organized them in different tables for a better understanding of the similarities, but also the many differences that exist between them. All the guidelines consulted come from these places. It is important to mention that most of the countries that don't have a guideline rely on the European one. These are the topics that we will be discussing: indications, contraindications, complications, and compression. We start with indications. The most important thing to point out is that there is no limitation for sclerotherapy. That is undisputed. General agreement is reported in different continents' guidelines regarding indications for sclerotherapy. There is consensus for the treatment of an incompetent saphenous vein, tributary varicose veins, and many others. However, a discrepancy among guidelines is the maximum recommended sclerosant foam volume per session, 10 ml for the European guidelines and 20 ml for the Australian guidelines. Moving on to contraindications. There is a lack of uniformity between the different guidelines. Many documents even differ on which is an absolute and which is a relative contraindication, like pregnancy of acute superficial thrombosis. The Indian guideline is the only one considering pregnancy as an absolute rather than a relative contraindication. Interestingly, the same guideline deems saphenofemoral junction incompetence as a relative contraindication. The most important absolute contraindication is the known allergy to the sclerosant agent. And the most common relative contraindication is the neurological disturbances after foam sclerotherapy. The Australian guideline mentioned, in our opinion, an important relative contraindication: lack of compliance. Something to take in consideration, especially because this is a treatment that requires certain care on the part of the patient for its total success. Complications. Sclerotherapy has proven to be a safe procedure, the safest one. Knowing all the possible complications makes it even safer for your patient. These complications are classified in severe and benign. We found an agreement in the severe complications, but those are at most rare. Most of the complications reported are benign. Visual disturbances, although very rare, are the most mentioned. The most common complications are matting and residual pigmentation, although we consider that these rather appear as a result of a bad sclerotherapy technique. In the topic of post-sclerotherapy compression, most of the documents mention that compression should be used. That is not discussed. However, there is no consensus about the duration time. It varies from 24 hours to 3 weeks, and the pressure values that range from 16 to 40 millimeters of mercury, according to the type of varicose vein treated in some guidelines. Sclerotherapy technique is not standardized. There is no specific guideline regarding several aspects of sclerotherapy. In example, materials, like the syringes and the needles that we use. The sclerosant agents that you use in every country is different, and the concentration that we apply in the different type of varicose veins, and so many more. Future international guidelines should focus on the evaluation of homogeneous data, discarding investigations potentially affected by bias, providing evidence-based support to what empirically has been the most frequently used practice in the phlebology offices all around the world. Foam sclerotherapy has resulted in the renaissance of sclerotherapy. That is why It needs to be agreed on by those who have treated the most patients. I would like to close my presentation with this picture. 7 years ago, I attended my first UAP World Congress in Boston alongside my father. There, I became part of the AVLS, named ACP at the time. So I want to thank you very much for having a LATAM session in this conference and considering me for this.